Rabina, we can begin with the CAHO anthem, please.
Yes, ma'am.
Rabina.
A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, work with passion like a breeze, train people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Good evening, everyone. Thank you for taking your time and joining this clinical indicator program. The last week, we completed 9 clinical indicators, and the program was well received. We had over 1,000 participants who joined us through Zoom and also through our live Facebook and YouTube updates. So today, we are going to be having another set of 9 indicators, and we have with us none other than Dr. Sanjeev Singh, who will be handling the first 5 indicators. Dr. Sanjeev Singh is the Medical Director, AIIMS Faridabad, Chief Medical Superintendent of AIIMS Kochi. He's a well-known name in quality management principles. He's implemented a lot of programs and projects, an excellent faculty, and today, sir, brings to us the 5 important indicators, and I'm sure it's going to be a great experience learning from Dr. Sanjeev Singh. Over to you, Sanjeev, sir, and thank you very much for accepting our invitation.
Thank you so much, Lalu, and congratulations for again bringing up all fantastic programs under CAHO. So great work, and I think what you do on weekly basis is a magic. It is a great service to quality and healthcare. So thank you for doing all the hard work. And I'd also like to thank your staff for coordinating, because I think on the background, there's a lot of coordination which is required, which they do wonderfully well. So thank you so much, and we'll get started. I will share the presentation. As Lalu said, basically, in the sixth edition, there was a slight change in the indicators, and it was felt that the clinical presentation has to be appropriate and the clinical indicators have to be brought in. And that is how there are these 18 indicators which are present. I'll quickly start without further ado. There is an indicator which is required, which is mandatory, which is sepsis. Now, we have done quite a good work in all the hospitals with infection prevention. We are doing decently well in all the accredited hospitals with respect to antibiotic stewardship practices, which is getting better and better each day. And thank you so much, all the hospitals and the healthcare professionals, for doing fantastic work. Sepsis, again, is a very important indicator. In a very simple language, sepsis would be if there is an infection. It could be device related or otherwise, which could be bloodstream, urinary tract, surgical site, pneumonias, plus if there is an organ damage. So in a very, very simple language, if there is an infection followed by an organ damage, that is called as sepsis. And this is very important to understand, to be able to capture, because this is all done at ER, where it is very chaotic. Patients have just come in. You have to take the briefing, your history of present illness and things like that, and presentation and act. So that is where it is extremely important. Now, as per the surviving sepsis guideline, which is the main body which basically guides what needs to be done, there are 5 salient features, and that is in 2002, basically this was all brought in. So one important marker is in lactates, and lactate more than 2 millimoles per liter is a good indicator of sepsis. So one salient feature for sepsis, which is basically life-threatening organ dysfunction, which has been caused because of this infection. One important aspect to prove sepsis and calculate this or start tracking is lactates. Second is that before giving an antibiotic, any broad spectrum at ER or at any place, either in outpatient setting, daycare setting, or in inpatient setting, it would be also important to obtain blood culture. We generally give antibiotic and then the blood cultures may present as no growth, and it may not be very substantial. So it is important. That's the second important thing. Third is a broad spectrum antibiotic according to your institutional antibiogram should be immediately given. So that is important to have your own antibiogram that should be known and that should be given. Fourth important thing is to replace fluids, because there is infection and then there is an organ damage, and that is where the fluid replacements are extremely important. So that is close to 30 ml per kg of crystalloids, which needs to be given at any given point of time, which could be basically either a normal saline or a ringer lactate or 5% dextrose. Accordingly, you can possibly take a decision. So what needs to be tracked is that the percentage of sepsis patients at ER and ICU who received this care within 1 hour. Earlier, when it got started by Surviving Sepsis campaign, it was 6 hours. And then it got reduced to 3 hours. And then they realized that the outcome has to improve better, and that now it has been reduced to 1 hour. And 1 hour bundle needs to be captured with all the 5 points which we mentioned. So the start time would be when the patient comes at the ER, or if they come directly, if they have been very critical, if they come directly into the ICU. So clinically, it is extremely important only because they are in a shock-like state, or it is a life-threatening, and organ damage is already there. So we need to act fast, and acting fast basically would happen because act fast is a good mnemonic for treating sepsis or at 1 hour bundle. A stands for antibiotic, C stands for culture, T stands for treating with IV fluids, F is a finding source. So source control in infection, as you would know, is an important indicator. And A stands for access vitals. According to the vital parameters, again, you would act on it. And then there is a support, which is given by crystalloids or vasopressors, and then transfer to appropriate setting. Now, how do you calculate it? The numerator would be all those patients where you have done 1 hour bundle capturing with those 5 salient features, and divided by those who are septic, those patients at ER or ICU, those who are septic. So again, I will like to say, because many of the patients may present at septic, many of the patients may present at acute kidney injuries, acute liver failures, looking like sepsis. So infection with an organ damage is a very simple example, and that should be tracked, and whenever there is life threatening. So, and that is how the example would look at if you have, and you could sort of benchmark it within your institutions because you have your own data. And if some patients are at 10 patients are sepsis, 9 you did, so that's 70%. How do you capture this information? It is through the lab reports, because you have sent some of these biomarkers, so you would know what exactly needs to be done. The ER medical record, because if the history would also say, and possibly you have done the SOFA score, and whenever you did a SOFA score, and if it is greater than 2 points, there is an indication of a life-threatening or a dysregulated host response, and that should be a good indicator. It should be done monthly. Responsibility is with any physicians who's the first point of contact or at ER. ER should basically handle it. Uh, a higher percentage shows a good trend, because this 6 hours, 3 hours reduction to 1 hour, 1 hour is definitely challenging. But then if it is done well, and if you are more than 70%, that is a good sign. The outcomes definitely would be better. Lower percentage would be a bad sign. There are no benchmark figures up till now, but then it is important that we react to it. So managing with those vital parameters would be critical. Generally, like a SOFA or Q-SOFA could also be done with a respiratory rate of more than 22, mental health status and BP of less than 100. So if 2 or more signs are available, that should basically be a good trigger to be able to understand that it is sepsis. We need to capture it and do all these 5 salient features. And it could be presented like this, a good average and a bad indicator, and that could be a representation. So there are challenges with respect to this. Lactates are missing, incorrect documentation is there, and we don't know whose responsibility is to capture. So what defines 1 hour sepsis bundle? Basically all the above, because lactates have to be there, the antibiotic has to be there, fluids and vasopressor has to be there. Now, the next indicator, which is bile duct injury, and for all lap chole patients, and this is optional indicator. Basically, lap chole is one of the most common surgical procedures, so much so that now within the Ayushman also this has been taken out, because it has to be done at the public level hospitals. And there is a hepatic duct, there is a bile duct, and leading all to common bile duct. And during some of these surgeries, which is minimal invasive, there is a possibility of injuring the bile duct, or completely injuring it, which should be sort of avoided. And that's why one of the surgical indicators has been also brought in. So bile duct injury with lap chole is an important indicator to understand the good outcomes or a good surgical skill. The KPI is basically looking at the injury, which would be either intraoperative or postoperative. Intraoperative also, it could be identified, or otherwise the postoperative things could also be sort of looked at. The intent here is we are looking at basically critical view of safety. And there could be either intraoperatively, there could be a cholangiography which could be done to be able to sort of give an information that the bile duct injury has happened. Otherwise, post-operatively, there will be signs of peritonitis, there will be signs of sepsis, there will be signs of leakage, and there will be signs of bile collection. And that would be so this surgical decision making is extremely critical. And all these injuries is to be sort of reported. It has a lot of clinical relevance, because this is Other than hernias, lap chole is again and cesarean section. These are very, very common surgical procedures within the healthcare institutions. Numerators are the bile duct injuries, and the denominator is all the lap choles which has been done, and it is into 100. And you could basically, it's very easy to sort of calculate. How do you capture it? It comes from OT log. It is going to be very difficult to capture until unless there is a humility or an ethics um, in announcing that there is a complication, or there could have been a complication by the surgical team, or there could be a very vigilant nursing or attending surgeon team. So if there is a non-blame free culture, and if that is good, then the collection of this data would be very important. It would be very difficult to get it from OT logs and OT notes, but and announcing a self auto-correcting and from the surgical team would be the best. So how do you interpret? So high percentage would be a poor trend, and low percentage a good trend. There is within the there is a group which is called as SAGE, where they calculate this data, they pull in this information from all the institutes. So Society for American Gastroenterology and Endoscopic Surgery. Within them, they have said 1.5% is something which is an international benchmark, and you could possibly start from zero or look at that benchmark, and that would be easy start for capturing this surgical indicator. Now, there is definitely a problem because the surgeons don't report it, and they never claim that there is any complications from this the surgical procedure which they have done, and it is something else which could be responsible. So those are a cultural issue which needs to be set in, and definitely within the theater and OT notes, this would be somewhere missing. So a case of bile duct injury reported in post-operative period, will it be a case of bile duct injury? A question to all of you. Reported in post-operative period, will it be added as a numerator? Answer is yes, because even intraoperatively, post-operatively, we need to sort of capture this information, because this is part of the numerator and part of the bile duct injury collection of information. Now, we also looked at another obs and gynae surgical procedure, perineal tear, which is also extremely common. Within the National Patient Safety Framework of our country of 2020-2025, a 5-year plan, perineal tear was one of the common indicator which was supposed to be captured by all the public hospitals, and that is why it has been sort of made it mandatory. So the Royal College of Obs and Gynae and American College of Obs and Gynae basically have defined this very clearly. So these perineal tears are 1 to 4 degrees. So if it is a very small tear which is just affecting the skin, that's the first degree. If the muscle gets involved along with the skin, that's the second degree. If it is deeper than the muscle, that's the third degree. And fourth degree is if it is also involving anal sphincter. Third and fourth degree is going to be very, very risky. And that is where I think the multidisciplinary team also needs to get involved, and that requires, because it is going to be extremely effective, and it requires a lot of attention. So as an indicator, it will be percentage of vaginal delivery where the perineal tears have been divided by the number of surgeries, which has been performed. It is extremely relevant because even our own data, a published data in an Indian setting shows a very high percentage, and there are perineal tears happening, and this could be definitely preventable, and that is where it could be just the first degree, which is also okay, which could be avoided by the episiotomy, but definitely it is important to be sort of looking at. So numerator is number of vaginal births with spontaneous tear. Denominator is total vaginal deliveries into 100, and that's the very easy way to calculate the percentage. Now, where do you capture it? Now, because this tear is happening at the labor and delivery suite or labor and delivery rooms. So at their register, or if there is an obs and gynae records, delivery records, notes, and the team which also can announce. So responsibility lands up with those team, the faculty and the staff at the labor and delivery. It has to be done monthly. So higher percentage, it shows a poor trend, and lower percentage, it's okay. The published literature, that is in a practice bulletin, it has been reported as 53 to 79%, which is extremely high. And that is something which needs to be prevented and should be sort of taken care of. So we need to look at first degree tears, definitely could be a possibility because of tier 3 PHC, CSC delivery, but beyond that should be all preventable. And that is how it should be sort of presented, and good, bad, fair indicator. So common problems in the data capturing process is underreporting and missing of the delivery nodes. So a very quick question to you, and you can respond on the chat. What is the worldwide incidence of the perineal tear reported in the vaginal delivery cases? And I just mentioned there is a practice bulletin which reported this particular number. And that is why it is important in Indian setting to capture perineal tear as one of the indicators. So, right. So very good. It is basically 53 to 79%. And that is where it is extremely important to capture this information. Now, fourth, the indicator is looking at percentage of POCT, point of care testing, for any clinical intervention. So it's optional because it is just coming in our country. There are lots of point of care tests which got introduced during COVID. It could be PCR based, non-PCR based. It could be for just for good biochemistry. It could be a decent hemat. So it all exists within the hospitals. A glucometer is a good point of care test, which is very, very common. A urine dipstick test for protein ketones is again a very, very common test. So it exists in the hospital setting, and that is where it was important to bring it into one of those indicator and practice, because it helps in the good clinical decision. So point of care testing is a laboratory test which gets gets conducted at the bedside, and it could be electrolytes, it could be troponin, it could be blood glucose, blood gases. So all of it is not sent to the central laboratory system, and it is all done at the bedside for faster, rapid decision making. So one of the group which basically defines what consists of POCT is CLSI guidelines internationally. Nationally, they have still yet to adopt. ICMR has released the guidelines on POCT, which has been sort of also debated, but they have released these guidelines more so for areas in PHC, CSCs where the lab is not there, so point of care test can be introduced and the immediate clinical decision can be taken. WHO has offered a decent framework or POCT. Because it needs to be sort of sensitive, specific, and making it more affordable and rapid. So there is definite clinical indication of introducing point of care testing at bedside, whether it is critical care, emergency, or any of the procedural areas. Now, the numerator is number of POCT tests that resulted in treatment and intervention divided by number of POCT where the clinical intervention was deemed necessary. So deemed necessary is mostly in an emergent setting. It could be a patient coming in with STEMI, non-STEMI, and then you get an ECG done, and the other marker would be troponin. Or you don't realize whether it is alkalosis or acidosis, and you want to get an ABG done for clinical decision or an intervention. So that's how it would go, and it would basically gets captured from the POCT logbook, which is very difficult because it is there everywhere within the hospital, and non-calibrated equipment would be extremely difficult. It could lead to bad decision making. But then if there is an activity sheet, or if there is a result which has been sort of captured in the vital parameters or in the lab test record, you could sort of retrieve it from there. Responsibility would depend from the nursing rather than lab managers, because point of care test mostly is done in critical care setting and in emergency room setting. So it will be responsibility of the nursing to capture this information. Higher percentage shows a good trend. I don't know, I'd leave it to you for judging, but an immediate clinical decision is going to be very, very critical. And if it is done for something where the outcomes improve, it is a good sign. and lower percentage shows a low trend. Unfortunately, it is still coming in a decent way in our country. So there are no national and an international benchmark. So that is how it could be represented. That could be 100% is a benchmark, and then there is a good indication. Common problems for capturing is because it's non-calibrated, you don't know, it is not recorded, and it goes unnoticed, and intervention it gets done, but it is not documentation. Documentation, as you know, is a decent problem within our healthcare organization. So a very quick question, and you could respond is in a chat box. Which of the following will be captured in the KPI, which is POCT? So blood glucose check using glucometers, drop eye showing higher values, or lab test done to check creatinine. So which of the above would basically fall into point of care testing? So drop eye is one of those most favored point of care testing, because as American Heart Association has also said acute coronary syndrome, a very relevant test is ECG and drop eye. And that is where the decision making, and it needs to be immediate because you need to sort of move the patient to the cath lab and get a CAG followed by PTC if it is required, or primaries to be done. So finally, another last indicator from my side, it would be percutaneous intravenous contrast extravasation. It is mandatory because it's extremely risky. And there needs to be contrast is happening left, right, and center at nuclear medicine, at radiology, and there needs to be a decent precautions which needs to be taken. Now, who gives this particular guidelines? It basically comes from American College of Radiology or Royal College of Radiologists. And fortunately, in India also, the Society of Radiology has included this as one of the indicators to measure their work. So contrast extravasation is a problem. As a KPI, what we need to measure is the percentage of IV contrast administration, which leads to extravasation. It is a common indicator, and that is why it got included within this 18. And that was one of those indicators which was available for radiology, which we were not doing it earlier. Redos were done. The clinical correlation was done. External, internal peer reviews were already done. Radiation safety was already done. Clinical indicator which was left with is extravasation. That is preventable, and that is why it is of relevance that you need to improve the outcomes. What it could lead to is a higher degree of pain, maybe an increased stay, increased cost of the patient, and some treatment would also be required other than disturbing the quality of life of the patient within the hospital. So numerator is number of extravasation events. Denominator is total number of IV contrast which got administered, and that is how the formula is. So if there is one case divided by 100 CTs and MRI where the contrast has been given, it would be it could be 1%. Now again, it is very difficult to capture the source of this information. It would be basically coming from medical records whenever the patient is either shifted from nuclear medicine or radiology, or it would come from the nursing notes. So adverse event, if there is a very vigilant radiology group where they capture all the adverse event, so it may also come from the incident report. So there needs to be continuous flow. A higher percentage shows a poor trend. The National Radiology Society, basically IRIA, also says that there is a national benchmark of less than 0.11%. And almost similar reporting comes from American College of Radiology, which is 0.7%. So it definitely exists. If the organization doesn't have any data, they can start with 0, and it could be represented in various graphical form to understand whether it is good or bad indicator. The problems for data capturing would be underreporting, if there is an untrained staff and if they rush through the presentation or administration, and if the cannula was not in place and it wasn't patent. So a last question to all of you would be, and you could respond in the chat box.
Namaskar. Srino Bhavan Yoga.
Right. Sorry about that. That is our founder, Amma, who prays for everybody's health and happiness. So extravasation happening in chemotherapy patients while administering chemo drug is included in the numerator. Is it true or false? And so basically, we are looking at contrast. So it would be just limited to contrast. So anything else other than this would not be included in capturing this particular information. So thank you so much. I'll pass this baton to Dr. Sunil Mundkur, who is basically a very dear friend, a fantastic human being, a great clinician, and a professor of pediatrics at one of the finest medical colleges in the country. And he would be covering the rest of the indicators, and post that will be available for question and answer. So over to you, Dr. Sunil.
Thank you, Dr. Sanjeev Singh, for making my job so difficult.
Sunil sir, just 1 minute. Sorry. Thank you so much, Sanjeev sir. Would like to take this moment to introduce our next program. My team will be putting up the program. Dear friends, as you are aware, we will be starting the masterclass on department-specific indicators. Rabina, are you please, can you please screen share? Rabina? Yeah. So this is the masterclass series 14 of CAHO, Empowering Clinical Excellence, Clinical Indicators. We are planning to start on the 8th of August, every Friday between 4 p.m. and 5:30 p.m. We have one departmental indicators. The clinical indicators of one department will be discussed. And we have experts from these institutes, Aster DM from Dubai, Fortis Healthcare, Sriranga Hospital, Chengalpet, Dr. Mehta's Hospital, Chittaranjan National Cancer Institute, Ganga Medical Center, HCG Enterprise, Opolo, Sundaram, Nirmal Sai, Zamindar Eye Hospital, Institute of Neurosciences, Calcutta, Aster DM, Baby Memorial, Diagnostic Division of CAHO, Sakra World, Clinical Dietetics Forum of CAHO, Narayana Health Dental Forum of CAHO. So the 18 broad areas will be discussed for 18 weeks. That's the idea. So we will go in depth into discussing clinical indicators, let's say from cardiology and cardiothoracic surgery by the Fortis Healthcare Limited. So requesting all the participants to use this opportunity and register for this program. Registration links are open. There'll be a lot of learning, I'm sure, and there can be good discussions. All your questions can be answered. We are also going to be issuing a certification by end of the 18 programs. If you have any group booking, and kindly contact Anita or Meenakshi or any of the CAHO members. Thank you so much. I would now hand over to Dr. Sunil. Sunil sir, sorry for the interruption. You can continue.
Am I audible?
You are. Thank you, sir. Thank you.
Thank you. Are my slides visible?
Yes, sir.
Okay. Thank you, Dr. Lalu, and thank you, CAHO, for making my job difficult because it's challenging to talk after Dr. Sanjeev Singh's deliberations. Let me try to do justice to the topic and the hype and settings created by Dr. Sanjeev. So I'll be dealing with the remaining last 4 indicators which are left with. So the first one is on nuclear medicine. The indicator is percentage of adverse reaction to radiopharmaceuticals. Adverse drug reactions are unintended response to doses prescribed for humans. An adverse reaction may predict risk for future administration or warrant prevention or targeted treatment or changes in the dosage or withdrawal of the drug. The good news is that most of the radiopharmaceuticals are administered only once, and the reactions are extremely rare. So there is no question of changing the dosage or withdrawal of the drug or prevention of this drug administration in such scenarios. Any product that, when prepared for use for therapeutic or diagnostic purposes, contains one or more radionuclides or radioactive isotopes is called radiopharmaceutical. And radiopharmaceutical can be used for two purposes, that is diagnostic and therapeutic. Diagnostic agents are containing an isotope that emits photons or gamma radiation, which can be captured with the SPECT, or therapeutic agents whose isotope emits beta or alpha particles to ablate the tissues in the body. Unlike conventional drugs, radiopharmaceuticals rarely cause adverse reactions. However, when they do occur, they often cause alarm both to the patient and healthcare staff. And if you see the common adverse reactions to adverse radiopharmaceuticals as given in the NABH standard book, include nausea, decrease in blood pressure, hives, bradycardia, dyspnea, itching, chills, muscle cramps, bronchospasm, flushing, cough, and dizziness, for which you need not worry. I'll tell you the dangerous part of it subsequently. This is a mandatory indicator if it is in the scope, if the nuclear medicine in the scope, otherwise there's no need to capture this data. Frequency is monthly and it includes outpatient, inpatient as well as daycare patients. The numerator for this indicator is the total number of patients who developed adverse reaction to radiopharmaceuticals into 100 divided by the total number of patients receiving radiopharmaceuticals. So it's a percentage calculation, not a ratio. And the data shows you can retrieve it from EMR, HIS after entering the appropriate data. If you have totally electronic medical record, you can have a area or option to capture this data. There should be provision for entering the manual or electronically collected data, and you can have apps or online forms to capture this data. Nuclear medicine register can have this data, or who can collect this data? Either nuclear medicine nurse or technician in the nuclear medicine department, patient care coordinator or doctor. You can assign this job to any one of these to identify, to capture this data. What trends indicate improvement of concern? As I've told you, it's very, very rare incident that happens for adverse reaction to radiopharmaceuticals. Hospital has to develop its own benchmarks. The incidence of such adverse reactions are, internationally it is accepted that's around 0.01 to 0.1%. That is 1 in 1,000 patients may develop this kind of reactions, and majority of them are allergic reactions. So common challenges, as we have already discussed, is underreporting or wrong coding, acceptance, documentation gaps, and adherence. When I say acceptance, there are clinicians that it is an adverse reaction. Hence, whenever the department is capturing data, it's always important to validate the data for appropriateness. In fact, 88% of patients attending a nuclear medicine service typically receive a single dose of radiopharmaceutical. So there are no chance of repeating the dose, especially for diagnostic. For therapeutic purposes, yes, sometimes you may repeat. Aronson, etc., classified ARs into two types, that is predictable or dose-dependent based on the pharmacology of the drug, and unpredictable, that is not dose-dependent, that is idiosyncratic, unrelated to the pharmacology of the drug and often immunologically mediated. Of course, both of them cannot be controlled or anticipated and prevented. Although estimations of the incidence of adverse reactions vary, they cause morbidity and mortality and involve significant cost to the healthcare system. Most adverse radiopharmaceutical reactions are mild and require minimal or no treatment. This is a very interesting article. I think all of you should read. That is Gian Antonio et al. Adverse reaction to radiopharmaceuticals from Pharmacia Hospital area. Volume 45, it's in the downloadable format in the internet. It describes more than 35 radiopharmaceuticals and their adverse reactions are mentioned in this article. Also, it's important to report these adverse radiopharmaceutical reactions in the pharmacovigilance program if you are participating in the pharmacovigilance program. program. I'll just give a glimpse of this, how it is described in that article. And what I would like to inform you here is, although majority, I think more than 90% of them are minor allergic reactions. So for example, DTP is one of the commonly used radionuclear pharmaceutical, and it can have signs like meningitis. Then even fatality has been reported following DTP scanning. Cardiac arrest has been reported. So it is not only important to look for or watch for these adverse reactions, but also report so that it will be easy for others to be cautious. This is another important study done by Schroeder et al. This was a patient-reported radiopharmaceutical reactions, and majority of them are general disorders and administration site conditions, and very few are nervous system disorders, and majority of them otherwise are rare. So what the paper concludes by saying that general disorders and administration site conditions and nervous system disorders are the most common. The reported frequency of patient-reported adverse reactions to diagnostic radiopharmaceutical was 2.8% in this study. And none of the adverse drug reactions related to the administration of diagnostic radiopharmaceutical were considered to be an important medical event, because there are very subtle, and a few medications like chlorpheniramine maleate or antiemetics would solve the problem. Most events occurred shortly after the administration of the radiopharmaceutical and were resolved within a few hours, while 20% of the events occurred later, and these took longer time to resolve. That's what the article says. Very interesting article. All of you should go through it. So having said that, whether these adverse reactions or the allergic reactions can be prevented by pre-medications. There are a few large-scale controlled trials on pre-medication treatments, but usually not necessary. Evidence mostly comes from the case reports, expert opinions, and clinical guidelines rather than a case series or a series of events. Usually reserved for patients with known hypersensitivity or high risk of reactions or allergic, and diagnostic radiopharmaceuticals usually no pre-medications required. This is what the recommendation is. For the therapeutic radiopharmaceuticals, pre-medication might be needed depending on the agent and the patient, depending on the previous administration experiences. You may have to give anti-appendix or anti-allergics. Otherwise, most often it is not required. Organizations like ENM, that is European Association of Nuclear Medicine, and SNMMI, that is Society of Nuclear Medicine and Molecular Imaging, do not generally mandate pre-medication, but recommend monitoring for reactions and report it through pharmacovigilance program so that others are alerted for possible adverse reactions following neuropharmaceutical administrations, nuclear pharmaceutical administrations. That is the first indicator. The next indicator I'm going to discuss is on ophthalmology, that is post-operative endophthalmitis rate. Endophthalmitis is a severe inflammation of the inner structures of the eye, often caused by infection. It can occur following various procedures, including cataract surgery, intravitreal injections, and pars plana vitrectomy. It's called acute within 2 weeks of operation or delayed onset more than 2 weeks after operations. Post-operative endophthalmitis is an inflammatory condition of the eye presumed to be due to an infectious process from bacteria, fungus, or rarely due to parasites that enter the eye during perioperative period. All patients undergoing cataract surgery should be evaluated for any potential risk factors that can enhance the development of post-op endophthalmitis, and it is characterized by pain, redness, decreased vision, and can lead to vision loss if not treated promptly. So managing the intraoperative risk and prophylaxis protocols should be considered in order to reduce the risk of endophthalmitis. And early follow-up after cataract surgery is highly recommended to detect any sign of endophthalmitis, so as to treat it immediately and ensure patient compliance on post-surgery medication and precautions to reduce the serious complications caused by late diagnosis and treatment of post-cataract endophthalmitis. And then nowadays, most of these cataract surgeries and ophthalmic surgeries are on daycare basis, so you need to have a strict follow-up protocol so as to detect early and treat this post-operative endophthalmitis. The most common causative organisms are mainly from Staphylococcus group, Coagulus negative, Coagulus positive Staphylococcus, Staphylococcus epidermidis. Then the gram-negative bacilli, Candida, Haemophilus influenza, Streptococcus species, Pseudomonas and Propionibacterium are the most common organisms. I'm highlighting this because your antibiotic coverage should cover all these possible organisms. In the past, endophthalmitis after cataract surgery was accountable for the majority of cases, but is becoming less frequent due to the progress of surgical techniques and demographic developments with a steadily increasing number of intravitreal injections. What are the factors that affect the final visual outcome in such patients? That include pre-treatment factors like diabetes, hemodialysis, baseline vision, signs of vitreous opacity, and different surgeries before endophthalmitis. Or the treatment-related factors like the choice factors between IVI of antibiotics alone, intravitreal inhalation of antibiotics alone, and vitrectomy combined with the IVI of antibiotics and the injection number of antibiotics. Post-treatment factors include retinal detachment and glaucoma and macular pucker. So this is a mandatory indicator if the ophthalmology department is in the scope. You have to calculate it monthly, and it includes OP, IP, or daycare surgeries, what you do. And the formula is very simple. The number of cases of postoperative endophthalmitis into 100 divided total number of ophthalmic surgeries. You can retrieve the data from EMR if the medical records is totally electronic, or there should be provision for entering the data manually or electronically collected data. Can have apps or online forms to capture this data. OT register can have this data in the ophthalmology OTs. And data from MRD or discharge cell also can be collected. And who can collect the data? Either it's a medical records officer or ophthalmologist or the patient care executives can collect this data and keep it ready. So what are the benchmarks? If you see what trends indicate improvement or concern, the incidence of postoperative endophthalmitis is very rare, between 0.036% to 0.36%. For cataract surgeries, it's around 0.03 to 0.3%. Glaucoma surgery and intraocular lens implantation is around 0.21%. And pars plana vitrectomy, it's very, very rare, approximately 0.0 to 0.05%. This is the international incidence of postoperative endophthalmitis. Even one postoperative endophthalmitis is a significant concern, because I think Eye Care Organization in NABH describes it as a sentinel event for postoperative endophthalmitis. So serious, very prompt interventions need to be done to prevent further endophthalmitis in such situations. Common challenges remain the same on reporting around coding, acceptance, and documentation gaps, adherence, etc., and data validation to be done if it is done from the clinician side. The next indicator I'm going to discuss is on the rehabilitation, functional gain following rehabilitation. This is the indicator. Functional gain refers to improvement in physical activity and quality. It is a measure of improved physical function, means to say increased strength, flexibility, coordination, and balance, allowing individuals to move more easily and perform tasks like walking, dressing, and eating independently. Enhance self-care abilities, like the ability to perform personal care tasks such as bathing, toileting, and grooming, and better communication skills, like to improve their ability to understand and express themselves. It's also a measure of improved cognitive function, like addresses cognitive impairments like memory, attention, problem solving, which can impact the daily living. Increased participation in daily life, and that is ability to participate more fully in social, recreational, and occupational activities, and enhance psychosocial well-being, that is aiming at increased confidence, reduced anxiety and depression, and an overall improvement in the quality of life. So that is what is meant by functional gain. And this is important to measure the functional gain following rehabilitation. And the good news from NABH is that it's applicable only to neurorehabilitation in patients. It's only for neurorehabilitation, and it's only for inpatient, not for outpatients or daycare patients. The frequency is monthly, includes inpatients only, and applicable to only to neurorehab. It says the sum of the functional gain achieved before the discharge in patients undergoing neurorehabilitation into 100 divided by the total number of patients undergoing neurorehabilitation. Very, very simple. The sum of the functional gain achieved before the discharge in patients undergoing neurorehabilitation into 100 divided by the total number of patients undergoing neurorehabilitation. I am sure that I have confused all of you. Let's see how to measure this functional gain. Before that, we will complete the usual stuff. That is, you can retrieve this data from EMR, There should be provision for entering the manual or electronically collected data, can have apps or online forms to capture. The rehab register can have this data. And who can collect this data? Either physiotherapist, rehabilitation nurse, or patient care coordinator can collect this data. The common challenges remain the same because underreporting, wrong coding, acceptance, documentation gaps, and adherence can happen. So need to have data validation always. So these are some of the measures of functional gain. There are many measures like Fiegel-Mayer assessment, work balance scale, 6-minute walk test, gait speed, and time duct. But one of the most acceptable, most internationally accepted measure is a functional independence measure. Also is recommended by NABH, that is FIM. We will be seeing much more on FIM. Before going to that, to note that this indicator is applicable only to inpatients. Applicable only to neurorehabilitation patients, example, stroke, trauma, spinal injury, or post-neurosurgery, etc. The organization shall, that means it becomes mandatory, use the FIM scale, functional independence measure scale, and this scale measures physical and cognitive disability ranging from 18 to 126. The minimum score in this is 18 and the maximum score is 126. Higher the score, more independence for patients. And this is measure of disability for a variety of population and is not specific to any diagnosis. So a little more information on FIM. It's a 19-item, 7-level ordinal scale used to assess patients' functional independence and level of disability. These are the 18 measures. There are 5 on cognitive items and 13 on motor items like eating, grooming, bathing, dressing, upper body, lower body, toileting, bladder management, bowel management, bed chair, wheelchair, toilet, tub, shower, walk, wheelchair, and stairs. And the cognitive items include comprehension, expression, social interaction, problem solving, and memory. These 18 measures are measured under the scale of 5. The scoring levels are 1 to 7. 7 indicating complete independence, 6 modified independence, 5 supervision, 4 minimal assistance, 3 moderate assistance, 2 maximal assistance, and 1 complete assistance. So each score is multiplied by the scale 1 to 7, total assistance to complete independence. And again, it is very clearly mentioned in the FIM rating that the total assistance is totally independent for more than 8 hours a day, or 31 to 53, that is level 2 maximum assistance for 6 to 7 hours. So this is how it is graded based on the FIM scoring. And since there are 18 measures into 7 scores, so it comes to the maximum score of 126 and the minimum score of 18. So 1 to 7 scoring. So even everything, if he scores 1, so the total score will be 18. That means to say total assistance is required is in level 1. And as your rehabilitation improves the functional impairment, then the score may improve and score may accordingly increase in such situations. That is what you need to have. Here they specifically say the burden of care ends at level 6 because after 6, it is patients are totally independent and they can take care of themselves. That's what it mentions. The FIM instrument refers to a scale that is used to measure one's ability to function with independence. Score is collected within 72 hours after admission to the rehabilitation unit, within 72 hours before discharge, and between 80 to 120 days after discharge. So this is the recommendation by the FIM instrument. So it should be collected within 72 hours and then 3 days before discharge and between 80 to 120 days after discharge. Score ranges from 1 to 7, with 1 being the lowest possible score and the 7 being the highest possible or the best possible score. A final summed score is created and it ranges from 18 to 126, where 18 represents complete dependence, total assistance, and 126 represents complete independence. FIM scores and discharge disposition. With the high FIM scores, that is usually after 80, indicate a high level of independence and are strongly associated with the discharge to home. Patient can be discharged if the FIM score is more than 80. Mid-range FIM scores show variability in discharge destination, with some patients returning home and others requiring more support. They may be referred to a lower level of healthcare to support a few more days. Whereas low FM scores, typically below 40, suggest a greater need for assistance and are more likely to be associated with a discharge to a facility because they may require a lot of support for a prolonged time. So a total FIM gain of more than 22 or motor FIM gain of more than 17 reliably indicates clinically meaningful improvement during rehabilitation. This is a kind of benchmark which they have given. I repeat, a total FIM gain of more than 22 or more, a motor FIM gain of more than 17 reliably indicates clinically meaningful improvement. A cognitive FIM gain of more than 3 also reflects noticeable change through cognitive scale, though cognitive scale is less responsive overall. Cognitive scale, more stress is given on the motor scale rather than cognitive scale here. Cognitive scale more than 3 reflects noticeable change, though cognitive subscale is less responsive overall. These thresholds are valuable in outcome tracking, goal setting, evaluating care efficiency, and discharge planning. Although it recommends 3 FIM scores during the hospital stay and after discharge, you can apply as many as possible so that it's a measure of your rehabilitation services and it evaluates your care efficiency also. So benchmarks I've already discussed. So there are no international benchmarks. The idea is only to improve. I can suggest a few like 100% calculation of FIM score at discharge for discharge planning. Your discharge planning should depend on the FIM scoring at 3 days or before the discharge. 80% of the neuro rehab achieve a FIM score of more than 80 at discharge. That means to say they are much more independent. And 30% increase in FIM score at day 3 versus day of discharge in 80% patients and above. This is just an arbitrary benchmark which I have given. You can have your own hospital benchmarks and you can follow it up. I repeat, 100% calculation of FIM score 3 days before discharge so that you can plan your discharge based on the FIM score. 80% neuro rehabilitative achieve a FIM score of more than 80 at discharge and 30% increase in FIM score at day 3 versus day of discharge in 80% patients and above. So that it's a very, very good measure of your neuro rehabilitation services in your hospital. So I stop at that point. You can read further. Those 2 articles which I have mentioned are very good, very useful articles. You can go through this. That is, one is Gadomski et al. And another one is the Uniform Data System for Medical Rehabilitation. This is directly from the FIM who introduced FIM. Is the persons who introduced FIM. The 4th indicator and last indicator for today is in the emergency department. The time taken for triage. Triage is a process of prioritizing patients based on their severity of the condition so as to treat as many as possible when resources are insufficient for all to be treated immediately. The sorting of patients according to the criteria which ensures that the most seriously ill or injured patient is treated before patients with less serious problems. And many of us have got this confusion whether the time taken for triage is same as the time taken for initial assessment in the emergency department. The answer is a big no. There are 3 different time you need to monitor in the triage in the emergency department. That is time taken for triage, time taken for initial assessment, and time taken for disposition. So these 3 are different topics altogether. The only thing is the common time, the common finding in this is the start time, that is time at which patient has arrived. All the 3 will have the common time, the time at which patient has arrived to the emergency department. The end time for the time taken for triage is time at which triage is completed. Initial assessment is time at which initial assessment is documented. And disposition is the time at which the patient is disposed from the emergency department. So it becomes mandatory because most of the hospitals do have this emergency department, and it has to be collected daily for every patient and to be evaluated monthly. The indicator is very simple: sum of time taken in minutes for triage divided by total number of patients coming to the emergency. Please note that there is no multiplier. So it is on an average, what is the number of time, what is the time taken in minutes for triaging every patient. You can retrieve this data from EMR, or there should be provision for entering the manual electronically collected data. Can have apps, online forms to capture, register can have the data, and who can collect the data? Either ED doctors, nurse, or patient care coordinators. Again, underreporting, wrong coding, acceptance, documentation gaps, and adherence can be the challenges. Please do a data validation, because whenever we go for the assessment, we see that the benchmark is given that the patient should be seen within 5 minutes in after entering the emergency department. And when we look at the record, it says patient came at 9 o'clock, 9:05 he is seen. A patient came at 9:15, 9:20 is seen. Patient came at 9:17, patient was seen at 9:22. Usually the data entered is 5 minutes after the entry of the patient. Actual data may be different. So please do not do such waste exercises. Please try to track the real-time data and try to get the benefit out of it. Again, the start time, I told you all the three indicators have the same start time when the patient entered the emergency department. Time at which patient entered the emergency department versus the end time is when the triage is complete. A very, very interesting article from Acharya, RP, and et al. On emergency department triage with an ethical analysis, and very, very interesting findings are there in this. Please go through this article. Very, very interesting findings are there. And most of our hospitals do oscillation triaging scale, that is level 1 to 5. And the oscillation triaging scale, ATS, which is applicable in Australia and New Zealand, indicate these benchmarks. That is 0 for level 1, that is where resuscitation is required. Other emergency patients, it's less than 10 minutes, urgent less than 30 minutes, semi-urgent more less than 60 minutes, and non-urgent less than 120 minutes. But most of us do happen, all these kind of emergencies, we do address them within triaging within probably 5 to 10 minutes. It happens. Aim for 97%. This is what is recommended by Australian triage scale. Aim for more than 97% compliance for levels 1 to 2 and more than 90% compliance for level 3 to 5. This is what is Australian triage scale mentions. Very similar triage system is there in the Canadian triage than the acuity scale. Again, the same level 5 and almost the same except for I think 15 at level 2. Otherwise 0, 10, 30, 60, 120 remains 0, 15, 30, 60, 120. That remains the same. They are given the targets that more than 98% in level 1, more than 95% in level 2, more than 90% in level 3, more than 95% in level 4, and more than 80% in level 5. So it depends on the lower seriousness of the patient. You can take a little more time in triaging these patients. And they also say that more than 80% compliance is required based on whatever benchmark you have put in your hospital. A very similar triaging system based on the Manchester triage system, mainly used in UK and Europe. Again, the categories are same, level 5 categories, but the timings are benchmarks they have given is like 0, 10, 60, 120, and 240. Whereas some countries like Germany, the target for level 5 is less than 120. And these are common triaging systems. I will not go into the depth of this. 5 triaging systems. Many of you are following it. Please continue the good habit. In Indian benchmarks, if you see All India Medical Science Protocol disposition timings, this is also called as disposition time. Here refers to being seen by a clinician and not discharge time. For the red cases, it's around within 10 minutes of arrival. For yellow, within 30 minutes, and green within 4 hours. They have mentioned as the triage protocol. So time to initial assessment from arrival to first clinical assessment for ambulance arrives is less than 15 minutes. So this is now the most of the hospitals do pre-hospital assessment and triaging. So the triaging would have been already done during the transit time in the ambulance itself. So it should not be more than 15 minutes when they arrive in the emergency department. This is a very, very important article, actually downloadable format PDF book. Operational and Technical Guidelines on Emergency Care Services at District Hospitals from Ministry of Health and Family Welfare, Government of India. A lot of information on emergency care is there, including triaging. So you can download this book in the internet and follow it. These are the standards which are applicable for district hospitals under the government sector. There is an interesting study done by AIMS, All India Medical Science, Delhi, a quality improvement project aimed to reduce the door to triage wait time from 50 to under 30 minutes. And they did a lot of measures to reduce it. After 6 weeks, they could strike a median time of 12 minutes. An amazingly fantastic job done. You can go through this article also, which is available, mainly done by Ashok Deorari et al. So that's about, in a nutshell, about the 4 indicators which I'm supposed to discuss. If there are any questions, please feel free to ask.
Thank you. Thank you so much, Sunil sir. There are a couple of questions. I'll start from your questions. So the one is, could the triage completion time and assessment completion time be the same?
No,
I
no,
think you answered
I
that.
have already answered.
Yeah. So certainly the PowerPoint presentations will be shared with all of you. The first set had about 900 plus registrations, and today again another set of 900. Many of you could not join because our link is limited to 500 plus. So what we would be doing is to share the presentation with all of you. All the 4 presentations, maybe we'll put them all together and share with you. Then about, yeah. In case 30 patients are admitted daily and we do GRBS for 10 times, do we need to capture all? I think Sanjeev sir, the most controversial indicator is the point of care testing. One person has also asked for a repeat of that. There are several questions on POCT. Would you like to take them, sir?
Yeah, so can I take the questions what has been written one by one?
Yeah, let me, okay. One is by Arun Kumar. In case 30 patients are admitted daily and we do GRBS for 10 times, which is 30 into 10. I don't know why they would do for all of them. Do we need to capture all?
Yeah, the point is yes, you need to capture all because we are doing point of care testing only for clinical indication. And wherever there is any hypo or hyper, you intervene, and that is where that would come as a numerator.
I think that's exactly the question another person has also asked.
Yeah.
So do we need to include all of that? Okay. So the other important question is it only limited to a particular point of care testing, or ultrasound on-site, portable X-ray, all those should also be considered?
So this is a very, very good question, and it has to be considered. With an ultrasound, it is called as focus point of care ultrasound, and those are again very important for clinical decision making. So other than the lab, sonography is included, and it should be definitely considered.
Exactly. Including all the echo, ultrasound, everything, isn't it?
Correct. Bedside, yeah, bedside,
Bedside.
all these procedures, yeah.
Yeah.
But that's a good question.
All right. Yeah, the same question is repeating again with regards to the number of times glucometer and yeah. All right. If there are any questions, kindly put them up. Yeah. So somebody, Kirti is asking, is it not under biochemistry? Maybe the GRBS one, sir. But it is using the glucometer, isn't it? That's when.
Correct.
Yeah.
So it is dependent on wherever the geography is. It could be ICU, it could be ER, it could be under biochemistry also. It is hospital dependent. Wherever you can track this information, that can be done.
Yeah. So again, the extravasation one, sir. Should it be in cath also? Contrast in
Yeah,
cath lab should be.
absolutely. Yeah, absolutely.
Yeah. Sometimes the GRBS is for monitoring, Q2H or Q4H monitoring. Should that be also as part of the indicator?
100% because the definition of point of care test will remain the same. So your denominator will remain the same. On some of it, you are taking a clinical intervention. So that's a numerator. So denominator will not change. So even if you are doing it for screening, that will remain.
Yes, sir. Now this is to Sunil, sir. If we are using the Barthel index for checking functional capacity of patients after physiotherapy, do we have to introduce the FIM scale, FIM scale? Because more or less all the parameters are the same.
The NABH standard recommends FIM scale, and they have mentioned specifically FIM scale. So it's better to shift to FIM scale because it also indicates cognitive abilities.
Then from Dr. Rajshri, monthly about 2000 plus patients go to the ER. Time is manually entered in the ER register. For monthly triage time analysis, can we use sample size or should we take the entire thing? That's her question.
It's the entire thing. Since you are documenting it in the record, you can make an electronic or Excel sheet and record this, and it will be easy for you to capture the data. Take it for 100%. There's no problem. It's good for you to capture.
Absolutely. Since already you're capturing anyway.
Yeah.
Then Ajay also is the same question. Can we take the sample size for the emergency indicator?
It's better not to. For emergency indicators, it's always 100% sample that's required. And it is easy to capture also. When you are capturing the data, capture it for 100% and then capture it. The sample size, then sampling, then stratification, and then all those additional points will come. So it's better to capture for 100% data.
Perfect. There is a clarification, I think, Sanjeev sir. NABH book says that POCT needs to be captured in biochemistry only. So please explain why we are taking bedside ultrasound and X-ray.
I will I will refer and then come back if it is limited. Just give me a minute.
Yes, sir. Any tool for neonatal sepsis, Sanjeev sir?
It remains the same. We basically are looking at only, as far as the indicator, we are looking at 1 hour bundle, which is true for everybody, which is true for neonatal, pediatric, as well as for adult.
All right. I think that's about it. Thanks, everybody. Sanjeev sir, you are checking and you'll clarify that, isn't it? Maybe we can even, we can send a note also, Sanjeev sir.
Okay, we'll do that.
I think we'll do that. So we'll clarify this doubt, dear participants. So once again, I wish to thank Dr. Sanjeev Singh and Dr. Sunil Mundkur for the wonderful session. And what we are going to be doing is to share the PowerPoint presentations used by all the 4 speakers, rather 3 speakers. Sunil sir handled 2 sessions last week as well. So the PowerPoint presentations will be shared with all of you. Some of the questions that we have noted down will also be shared with the answers with you. And I would like to take this opportunity to propose to you to join another program which will be very, very interesting for all of you as quality managers, leaders in quality improvement program. That is about the department indicators that's coming up. It's a masterclass series with about 18 sessions. So if you have not registered, kindly register for this program. Any clarifications and any queries regarding this particular program that we are launching, kindly contact Anita at CAHO. So if you wish to join for all the 18 masterclass sessions, you could do that. Or specifically, some hospitals may want their cardiothoracic surgeons and cardiologists to attend one session. Then you can pick and choose as well. So this is a good way to get your clinical departments also involved in this exercise. And this carries CAHO credit points of about 18. Dear participants, those who wish to stay back for the valedictory of the certificate program, along with the Indian Institute of Public Health, CAHO and Indian Institute of Public Health, please remain. We are going to have the graduation ceremony now, and we have some guests who are joining us from the Indian Institute of Public Health. Meenakshi, can we go ahead and start with that program?
Yes, ma'am, we can.
Just one clarification, Lalu.
Yes, sir.
Right, it is right now only labeled with biochemistry. Rest
Okay.
of need not be captured. So that's one clarification. I'm sorry about that.
So we limit ourselves then to
Biochemistry.
biochemistry. That involves the ABG as well, isn't it?
Absolutely. Absolutely.
Yeah. Perfect. Thank you. So your doubt is clarified. I think for all of us, it's clarified as well. But it's not a bad idea, sir, to capture.
Absolutely.
Yeah, point of
Every point of care.
sound. Yeah. In fact, those make better sense, I feel.
Yeah.
Capturing X-rays, point of care, mobile X-rays, everything. So thank you so much, dear participants. So let's begin with the valedictory ceremony. Meenakshi, kindly start the program.
Yes,
Meda?
ma'am.
Dr. Meda, can we
Yes, ma'am.
start?
Yes, ma'am. I think Just a minute, I think Srivastav sir is joining, ma'am. So in a minute, he will be there with us. Our
Yes.
faculties have joined.
All right. So can you go ahead and announce the launch of our next batch so that our participants are with us now? We can take this time. Meenakshi, can you please put up the flyer for the next program? We'll be launching very shortly.
Yes. So I'll hand over to Dr. Apoor for announcement. And if Meenakshi can put up the brochure.
Yes, ma'am. Nisha is screen sharing.
Yeah, Dr. Apoor.
Yes. So, hello everyone. So, I'm Dr. Apuro Kumar Pandya from IIPAG. So, in collaboration with CAHO and Center for Quality Improvement and Patient Safety, I am very happy to share the announcement of online certificate program in quality management for healthcare professionals, and the second batch will commence from November 15th 2025. So this course is basically for healthcare professionals, quality managers, practitioner, clinicians, particularly nurses, and anyone working in the area of hospital administration and quality improvement program in healthcare discipline. And this program is also suitable for students who are pursuing their career in health management or healthcare administration. And this course basically will cover very critical area of the quality management. Particularly, it covers 8 major modules, which begins from overview of quality approaches and quality management techniques, accreditation standards, the quality assurance system in hospitals, particularly tools and techniques for quality management. Apart from these, there are sessions related to leadership, communication, data driven decision making, and importantly, legal and ethical issues in quality management, and driving sustainable quality initiatives. So this is a very comprehensive program, covers hardcore quality improvement initiative, quality improvement management principles, to some of the soft skills aspect of leadership and communication, to understanding ethics and legal framework, which is important in healthcare discipline. So request everyone to share this detail, and looking forward to the next program.
Thank you. Thank you so much, Dr. Apoor. Good evening, dear friends. Thank you very much for joining us. It's a very, very proud moment for us, both at CAHO and I'm sure at the Indian Institute of Public Health. We are delighted to partner with IIPH, and it's been a great relationship working together and launching this program on quality management. So I take this opportunity to welcome all of you for the valedictory ceremony of the certificate course in healthcare management for healthcare professionals. As Secretary General of the Consortium of Accredited Healthcare Organizations, it's my proud privilege to welcome on behalf of Dr. Vijay Agarwal, the President, the patrons of CAHO, and all the governing committee members of CAHO to this wonderful evening, celebrating the success of the participants who have been with us for the past 3 to 4 months interacting with us. So let me now hand over to Dr. Deepak B. Saxena. He is MD in Community Medicine, postdoc in Epidemiology from Karolinska Institute, Sweden. He is currently serving as the Director of the Indian Institute of Public Health, Gandhinagar. Dr. Saxena is a very well-known figure in the field, and he's been instrumental in setting this program along with Dr. Mehta and Dr. Apurva Kumar. So I request Dr. Deepak Saxena to give the address to the participants. Over to you, sir.
Yeah, so to all the participants, Dr. Deepak Saxena could not join because of his some prior urgent commitments that have come along. But he has sent his wishes to all the participants, has given congratulations to all the participants for successfully completing the course. And he has also said to take this opportunity to open the batch for the second batch for the same course. We have received excellent feedback, and as Dr. Apurva Pandya has just briefed about the course, so it's a live course for 16 Saturdays, 2 to 5 p.m. And I think I would request a lot of other participants who are there with us online to take this opportunity to collaborate with us for this initiative on the certificate course for quality management for healthcare professionals. And taking this forward, I would now, without wasting a minute, we have our chief guest, Dr. J.N. Srivastav, sir, with us. Sir is working as an advisor in quality improvement and patient safety division at National Health System Resource Center, which is the apex technical support body under the Ministry of Health and Family Welfare, Government of India. He and his team leads quality assurance and patient safety initiatives under the National Health Mission, which is the flagship program for the government for improving access, equity, and quality in the public health system. Under his leadership, the National Quality Assurance Standards, NQAS, for every level of primary and secondary care facility have been developed. The Standards Quality Assessors Training Program and NHSRC as a certification body are accredited by ISQA. Last year, Quality and Patient Safety Division NHSRC has been designated as a WHO collaborating center. He also leads efforts for improving hygiene and sanitation, strengthening IPC practices and wash in health facilities under the ambit of Kayakalp initiative of the country. Sir Kushal, an initiative of NHSRC that promotes assessment of secondary care health facilities on patient safety parameters in India. An alumni of Medical College Gorakhpur, Dr. Srivastav acquired advanced qualifications in family medicine, health systems management, and industrial health. He is an elected member of National Academy of Medical Sciences and founder member of Indian Society of Hospital Waste Management and Health System Action Network. Sir, we are privileged to have you with us, and with all regards, on behalf of CAHO and IIPHG, I welcome you for your keynote address, sir. We hand over the webinar to you, sir.
Thank you. Thank you so much. I hope I am audible.
Yes, sir.
Yeah. Thank you so much. Thanks. So at the outset, it is nice to see Dr. Joseph after a long gap, and
Thank you, sir.
Grateful to IIPH Gandhinagar, CAHO, Dr. Vijay Agarwal, whom we have been meeting in different forums, and other organizing team at the outset for reaching out to me and inviting on most appropriate day, that is a Saturday. Because for us, it becomes most appropriate because on that day, ministry is also half day working or at times expecting not much, disturbance in that sense. So I must compliment about, CAHO and IPH Gandhinagar for having thought, conceptualized, and come out with this program, which is in fact the need of the country. Need of the country in the sense when we talk from the health system's point of view, that it is not the private, corporate, for-profit, not-for-profit, or organized sectors like railways, defense, ESIC, etc. All of us must have experienced, must have seen the kind of harm which the patients undergo or the potential situations where they could have been harmed. And with so much of the investments taking place from different quarters, but are we getting the commensurate health outcomes? That remains a challenge. What percentage my patients are satisfied. That is also a challenge. And the more importantly, are our health delivery or the services, are they benchmarked against some national standards or any state government standards or even the standards which are there set by a different institutions? And the more importantly, that how do we make a decision, health seeking, I'm talking about the health seeking behavior. So I'm sure that during last 3 to 4 months of your journey, you all of you, I'm given to understand are the practicing quality professionals in different hospitals, in different health settings, must have experienced these challenges. So in the coming, say about whatever time is there, about 20 minutes, 25 minutes, I will try to give an overview what the government is doing, what is the commitment of the government to that extent, and what should be the roadmap and what are the challenges which are coming up. So I will, if I can share my presentation, let me see if I can show. Just a minute, it is again throwing up me some challenge, just a minute.
If you want to share your presentation with us, sir, we can share.
No, I have been able to sort
Yeah,
it.
yeah,
Then-
it's fine.
Yeah, I will just get it on the full screen. Yeah. So is it visible now?
Yes, sir.
Yes, sir.
Yeah, thank you.
Yes.
Because so I mean, in my introduction, it was nicely mentioned that Government of India launched the largest health sector program, that is the National Health Mission. And in the initial years in 2005 or 6, when this initiative was launched, that time the whole focus of the public health system, all the policymakers, all the service provider was to get those people coming to the public health facilities, because we all know that a country like as large as India, as diverse like as India, there are health systems, there are challenges, and there is a space for everybody around. And over a period of time, the health sector the public health system significantly lost its ground, and the people they did not trust the system. So in the initial, in fact, the years, the focus of the government was that these people should be coming to the public health facilities, not with any other reason, but because significant out-of-pocket expenditure has been taking place, and still it is a challenge in the country that India is one of the countries where our out-of-pocket expenditure remains high. And so in that context, this National Health Mission was launched. And after the people, they have started coming to the health system. The many interesting, in fact, the initiatives took place that in 2005, 6, 5 perhaps, when there was a famous case, Ramabai versus Union of India, that basically came out of the certain things going wrong in a family planning camp, which took place in one of the states. And on the court directive, the states were told that you got to be constituting a committee for the improving the quality. And each health secretary, each principal health secretary, they made a personal appearance in the court, and they gave an undertaking that, okay, we are constituting the committee. But those committees were largely focused on the the issues, the services which were getting delivered in the family planning camps. And interestingly, that time, in fact, the Quality Council of India, NABH, just came into the being, and there was a whole lot of confusion that what should be the roadmap for the country. And interestingly, in fact, just let me, if you look at this slide, where in the previous, in fact, the attempts, there was a somewhere vaguely it used to be mentioned that we will provide the quality of care. Whether it was for the RCH services, it means that reproductive and child health services, or the MCH services, or even in many non-government side, there was an attempt that, okay, we will provide the quality services. But what is that quality? How do we measure? And nobody had any clue. In fact, in 1718, Lancet Commission came out with the study where they had put that about 16 lakhs people that time were losing their lives because of poor quality of care. This data pertains to sometime in 1617. And I just want your attention on the row number 2, where it talks about that in totality, about 24 lakhs of the people, their lives could have been saved. I mean, this I just want to quantify the extent of the harm which low quality causes in our country. And so about say 8.5 lakhs people, they don't access the services for a variety of the reasons. But those who are accessing, about 16 lakhs of the people, they were losing the lives because of poor quality of care. In fact, after this thing gets over, I would request organizers, I mean, I don't have, this presentation could be shared, and the data source is given at the bottom of the slide, on this slide, where if you are interested, you can visit and see that information pertains to this was the global study. Information pertains to about 137 countries, which is available in the public domain also. So this is the harm we are talking about. Now, coming back to the thing which I was mentioning, that in 2005, based on the court order, this family planning committees, the quality assurance committees for the family planning services were formed. Also, under National Health Mission, the Indian Public Health Standards came out. I will just clarify that, you may be wondering that what is this NQAS, what is this IPHS, or Indian Public Health Standard. At IIPH, I don't know how many students are connected, but those who are working in the public health field would know that IPHS basically talks about, in a normative way, a good planning document, in the sense that, okay, what should be committed services at a particular level of the care, what would be the infrastructure, how much HR would be there, and then other supplies and other related issues. But when we talk about the quality, I'm sure that all of you are the practicing quality professionals would appreciate that India is a low resource setting, but unless we improve no two doubts that a certain amount of the infrastructure, HR, and the supplies and other things are required. I'm not trying to, in fact, negate that point. But the critical component becomes that how do we strengthen the process? And that is a challenge also. So the IPHS largely addresses the infrastructure part, HR part, for a given particular level of the services. But when we talk about the process part, it is not there. And in fact, in 2006, we were also struggling at NHSRC 7-8 that what should be the roadmap for the quality assurance in the country when there is so much of the variation taking place, all the health systems are different, and the resource challenges are going to remain there. We also tried out ISO 2000 and ISO 9001 quality management system, and a lot of good learning took place. But ministry got concerned that what should be the roadmap for the country. And then a study was asked by the ministry in 2012-13, where external agency Deloitte were the people who were engaged by the ministry, that okay, you suggest us that what should be the roadmap for the quality assurance system, quality assurance for the public health system largely. And it said, this study made, in fact, the three most critical recommendations. Few of these are still to be completed. Few are in the pipeline. One is that it recommended that there should be a national health policy on the quality as such. So as of now, there is a national health policy, but we don't have and which does mention about the quality, but there is no standalone national health quality policy as of now. Secondly, that setting the standards for the public health facilities. Also suggested that, okay, if there is some improvement which takes place, some incentivization should be there. And this, in fact, these recommendations catalyzed that we were tasked that, okay, NHSRC, National Health System Resource Center, we were asked that, okay, you are the Secretariat for Development of the National Quality Assurance Standard. So it is not that NHSRC all alone develops. We got in touch with the different partners, like many state governments, then all the program divisions which are there in the ministry, certain academic institutions like All India Institute of Medical Sciences, New Delhi, certain development partners like WHO, UNICEF, and many partners, and came out with this National Quality Assurance Standard. So in 2013 November, first time in the country for the public health system, we came out with the operational guidelines and simple NQAS are the National Quality Assurance Standards for the district hospital. That was the start point. In the subsequent years, all of you, few of you would recall that in the 3-tier system in the country for the organization of the public health system, there are CHCs. So in the subsequent years, this 2014, we came out with the NQAS for the CHCs and PHCs. In 2015, when the government the government launched Swachh Bharat Abhiyan, then on 2nd October, we thought that, okay, let's try to do, this was done in 2014, but it took some time for us that let's try to improve at least hygiene sanitation, infection control practices, biomedical waste, and other related things for the public health institution. In 2015, we came out with the CAHO guidelines. Subsequently, for urban health facilities in 2016, the NQAS for UPHC came, and then the WHO requested us that, okay, for adverse event following the immunization surveillance program, if you can formulate the standards. Again, we did the secretarial role, called certain experts, worked with them, and all of you would agree, those who are working with NABH and otherwise, that standard development does not take place overnight. It is, in fact, about good 1 year to 16 months for 18 months of good hard work. Then in the subsequent year, the Laksh. So Laksh is basically the NQAS certification of all the delivery points, because at that point of time, our maternity MMR, maternal mortality ratio, was pretty high, and then this Laksh is a very targeted approach for improving the quality of care in the maternity OT in the labor room where the deliveries normally happens. Mera Aspatal is another initiative. It is we firmly believe, and as a quality professional, you would agree that patient's voice is important. Somewhere we got to be hearing. So as of now, though we have started work for moving towards the PREM and if possible for the PROM, but Mera Aspatal is basically a system where if some patient visits a health public health facility, he or she will receive a call asking for the feedback in an objective criteria. Then in the subsequent years, we came out with the country came out with the patient safety implementation framework, and that's how the journey kept progressing. So, and the last being that NQAS for the IPHL, or the Indian Public Health Lab. These are the institutions, in fact, in the post-COVID period, these has been established in every district, where these are the integrated laboratories where at least 3 microbiologists, biochemists, and they are there. Sakushal is one of the patient safety initiative which we have undertaken. So as of now, this is in fact the broad key quality initiatives for the government of India where on the left side, if you see on this slide, where I'm talking about the National Quality Assurance Standards for the district hospitals, CHCs, PHCs, UPHCs, Kayakalpa I have already mentioned. Laksh is basically the targeted approach for improving the quality of care around the birth, around the delivery. And then the Muskan is for the pediatric services, providing the quality care to the pediatric population. But this has been the thinking earlier. Now the government of India is trying to bring everything together because the states are also getting confused that there are too many, say, initiatives. So let's have a unified approach. Mera Hospital I have just mentioned, AFI also mentioned about, and Sakushal is a patient safety initiative exclusively, where the hospitals, they assess that where do they stand. In fact, we wanted to have a patient safety accreditation program, but ministry advised us that for some time, let's stabilize the NQAS accreditation, then subsequently move on to Sakushal framework. So these NQAS framework largely is process driven, and in fact, depending upon the level of the facility, this 79% pertains for the district hospital. And see, infrastructure, following that, I'm sure that you would be familiar with the Donabedian model of quality of care. So we also took that same approach. But by a conscious call, the structure requirement we have kept minimal. The reason is very simple, that at many places in the standards, when we talk about the measurable elements are lower down in certain means of verification. We have said that whatever the infrastructure, whatever the HR is required, it should commensurate with the workload. The reason is that we have not been too prescriptive in terms of the infrastructure because there are challenges. But outcome got to be measured, and there are certain outcome indicators which are there. So as of now, under the NQAS, like we have all these three square accreditation in place. Our assessors are the surveyor training program is accredited. Standards are of course accredited, and our role as a certification body, which in fact last year in the month of March, the SQA auditors physically visited us and spent about 7 to 8 days. And our role as an accreditation body is also accredited. Last year in the month of July, about a year back, we also got designated as a collaborating center for the patient safety program in Southeast Asia. And these standards are duly recognized. The accredited hospital, they get impaneled, and they also become eligible for the gold category. And Insurance Regulatory Development Authority has also given a recognition. So this slide summarizes that what are the basic approach which has been taken. So in the initial year when the program got launched, the standards got launched in 2013, 14, and subsequently in the 14 for the PHC and CHCs. The efforts were focused in having a unified organizational framework. So in this slide, you will see in the next one that at the national level, we have created a Central Quality Supervisory Committee headed by Secretary in the Ministry of Health and Family Welfare, and it meets every 6 monthly interval. And at the state level, there had been the quality assurance committees. In fact, other than 1 or 2 UTs, small UTs, where there are challenges coming up. It's like UT of Lakshadweep is still there, though the committee has been formed but not fully operationalized. But we have been able to create an institutional framework, and all these people are getting supported. So under National Health Mission, the states are getting a support to the tune of about 90 crore rupees annually for the quality assurance program that is there. So the unified organizational structure in the initial years, as I mentioned, that our focus was in having these institutions created and making them operational. And they are being supported by the consultants in each and every state. And as of now, there are about 950 odd consultants are working directly for the quality assurance program. Then hand-holding support. Besides building the state's capacities, because in the initial years, the focus was, we used to drive from NHSRC, but now, because we realized that everything for a country like India, we cannot be managing while sitting in the Delhi. So we decentralized, building up the state's capacities has taken place. and there is a continuous effort. And last year, in fact, in the month of Feb, subsequent to the Chief Secretary's conference, the government took a decision that all the public health facilities will attain the NQAS certification by December 2026. Very ambitious target. Still, we are trying to figure it out that how do we move ahead. So this structure I've already discussed. At facility level, there are the quality teams. And in fact, in most of the district hospitals, there is a quality manager who are posted over there. This slide shows that what process we normally follow. So the first step is, like in any quality system, happens that undertaking the internal assessment, that how does it actually take place. Then there is a district level assessment which takes place, then state level. And after the state teams are satisfied, then only the facility comes for the national level certification. And we follow the same ISO 9001 say protocol, where the certification is for 3 years with the 2 surveillance in between. That is the system in place, which is of now. This slide gives us that these are the certification criteria which we normally follow. There are certain core standards, certain overall score, then individual standard score, and of course the patient satisfaction also has got one of the distinct criteria which are there built into the system. And so at the state level, like there are two categories of the assessors, quality surveyor or assessors, whatever name you want to call. That at the state level, these are the people who have undergone 3 days training and have exhibited some kind of proficiency. At the national level, the program which I was just mentioning a couple of minutes back, that the program is accredited by ISQA. There is a 6 days program which normally we conduct. And this is my pool as of now, that about 800 of them are clinicians, then about 250 of them are nurses, and about 800 of them are the public health professional. And approximately the past experience have been that about 65% of the people, those who undertake this 6 days training, they are able to clear the exam 65, 68, 70. That is in fact, has been the overall percentage. Over here, you will see that in each and every state and UT, at least there are some state internal assessor, means that these are the state's own internal assessor. External mean that those which have created. The third one is the Ayushman assessor. We realized that certain internal assessors, those who have undergone the training, state level assessors, way back in 2013-14, they have acquired adequate experience. So for them, we organize another 3 days module over here, and they become an Ayushman assessor basically for those smaller facilities. And subsequently, as they gain more experience, we'll be conducting another 3 days training for them, so that they become an external assessor. That is done. We also learned during COVID time, like any accreditation body, that virtual thing is not too bad. And it becomes a necessity also for the government system, that in the country, like you must be aware with the term Ayushman Arogya Mandir or the Health and Wellness Center, where not a qualified MBBS doctor is available. And there's a CHO or the community health officer who is primarily a BSc, having a BSc nursing qualification is there. So the process was resource intensive. So virtual certification protocol was launched last year on 28th June, with the caveat that 10 to 20% we undertake the surprise assessment, and which normally we disclose on the same day after the assessors they reach a particular, say in a particular state, particular district, that okay, these are the facilities which you got to be visiting. And we did some kind of analysis. We realized that those who are in the physical mode or in the virtual mode, it is more or less same. The government has also fully owned up the program. And in fact, it gets articulated in the different discourses, and it has put an extra pressure on us. So as of now, about say 37,000 facilities are NQAS certified, but this figure also includes the national and state certification all taken together. Laksh, as I mentioned, is an initiative for improving the care around the birth, say in the labor room and maternity OT. And this broadly has the 2 components. This is in fact the rapid improvement event which takes place that where there are certain structural improvement taking place, certain process improvements which are taking place, and the labor room certification takes place. And in this initiative, all the government medical colleges, district hospitals, and the first referral units. I'm sure that few of you may be wondering that what is this first referral unit. These are the designated, say, health facilities, either usually CHCs or the community health center or the district hospitals, at least where there is a minimal surgical care with the blood transfusion facilities, anesthesia facilities are available over there. And so this is a standalone certification of the labor room and maternity OT. The primary target being that, okay, I mean, there should be a fall in the maternal and newborn OT. And the country has, as a whole, if you focus your attention on this slide, would see that our rate of decline of the maternal mortality ratio has been much steeper than the global fall. Global decline has been in the range of about 50% or so, but India has achieved about 83% of the decline or so, I mean, during this period. Muskan, as I mentioned, this talks about pediatric services. And again, this is the departmental approach that in the district hospital, pediatric OPD, ward, SNCUs, and NRCs are the nutrition rehabilitation center. Because those of you coming with the public health background would appreciate that malnutrition is a problem with us in the country. And it is a departmental approach, starting from PHC, sub-district hospital, district hospitals, it is there. And the Muskan thing is also taking up. Till say last month, about 200 odd hospital health facilities or the health centers have attained the Muskan certification with certain tangible improvement. Kayakalp, as I mentioned, it is a focused approach for improving the hygiene sanitation, infection control, waste management practices, improving the support services. And there is a Kayakalp is an initiative which is largely managed by the state. There is a first level internal assessment, then there is a peer assessment system. And those facilities, those the institutions which are getting more than the 70%, they come for the external. So there's an assessment, there's an incentive, and there's a felicitation along with the certificate, which normally takes place, and normally all the states. In fact, let me inform you that this is the one initiative where there is a complete ownership by the political bosses. The reason is very, very simple. That felicitation gives them a kind of visibility which they look for. And so under Kayakalp, the assessment takes place on these 8 thematics. And in fact, initially there were from serial number A to F, that is from hospital or the facility upkeep, till hygiene promotion, where only that initial, say, thematic areas. Later on, we included the area beyond the boundary wall. The reason was very simple, that we realized that our hospitals, they are showing some improvement. But the area outside, a lot, I mean, there were overflowing drains, the roads being in apathetic conditions and other things. So there's a distinct theme which got introduced in 2018, beyond the boundary wall. And 3 years back, eco-friendly, in fact, the theme has also been introduced. Kayakalp, as I mentioned, a small beginning in 2015-16 with 100 odd facilities, and now about 48,000 facilities are in the previous financial year are the Kayakalp facilities which are there. So this is my last slide, though it is not that everything is honky-dory. I am very truthful and candid. There are challenges, and anywhere challenges are there, irrespective whether you are working in the public health system or in the corporate world or in the organized services like railways, defense, ESIC, or in our day-to-day lives. So first thing is that how do we scale it up? And because the states, they have their own challenges. There are, in fact, the issues of the people not having the understanding, particularly when I come to my standards which are there in the quality management system. There are standards when I'm talking about the outcome indicators. So we entered into a, say, collaboration with Tata Institute of Social Sciences, running a 2-semester program. Then also in between, we tied up with the Public Health Foundation of India for running the short duration courses. And since I IAPH Gandhinagar is also connected with CAHO. We would love to reach out to you if something is possible to run a small, say, module, something for our public health professional. Sustainability is a challenge because when it is going for accreditation, either for INQUAS or it is the kayakalp assessment, but certain deterioration takes place. And the last being that how do we bring a culture, that patient-centric culture, where the care gets organized around the patients and around the service provider. Of course, their role is equally important. So these are the certain few photographs, and that's all from my side. Once again, thank you to Dr. Apur Kumar, Dr. Joseph, and Dr. Vijay Agrawal. Please convey my heartfelt gratitude to him and to everybody for giving me this opportunity and sharing that whatever is taking place in the public health domain. Thank you very much.
Thank you so much, sir.
Thank you.
It was
Thank
an
you, sir.
enlightening session. Really appreciate, and thank you for taking your time.
Thank you, sir. It was insightful session.
Yeah, so on behalf of CAHO and IIPHG, we thank sir for his presence and giving an insight into how the public health system is also working and ensuring that quality care is being delivered to the system and to the population of our country. Moving ahead, because this is the valedictory, we'll take not a lot of time and we'll quickly jump to the feedback from participants, whatever we have received. So, Nisha, can you please? Yeah, thank you.
Dear CAHO team, we are extremely happy with the classes that you organized for all of us. The quality management for healthcare professionals. The classes were really excellent. Professors were excellent. The teaching was excellent. Definitely all of us have benefited from these classes. Thank you very much for taking a lot of pain, a lot of commitment, and a lot of hard work that you have put in. Thank you very much. We will ever remain indebted to you. God bless.
Hello, I am Miss Momita, working as a quality nurse at Fortis Hospital, Anandapur, Kolkata. I had privilege to attend quality management course by CAHO and IIPSG, and it has been truly enlightening. The sessions were practical, interactive, and deeply aligned with the real-world challenges in healthcare quality and patient safety. It helped me strengthen my understanding of NABH standard, various quality tools and technique, and implement structured quality initiatives in my unit. I thank CAHO for enriching experience and recommend to all healthcare professionals who aim to drive excellence in their organizations. Thank you.
Dr. Medha?
Yeah. So now we come to the formal announcement of the results, and we are here to announce, and initially we'll announce the winners of, not the winners actually, the position holders of our program. So we had undergone some series of examinations, and the results are, Nisha? First place goes to Miss Momita Saha and Miss Shakha Pani. Congratulations for securing first place. The second place goes to Miss Rajusha, Quality Officer, Deputy Nursing Superintendent, and Captain number 2M. Congratulations to both of you. And the third place goes to Mr. Vinod Kumar Khemka, Consultant Anesthesia, and Miss Suman Sri Ramaswamy, CEO and Director. So congratulations to the position holders. You all done a brilliant job. Dr. Manu wants to convey something. Yes, ma'am. So moving ahead to all the participants, Nisha, can we change the slide? Certificate of completion, Ms. Momita Saha. Congratulations. Next.
I think you can turn off the music. Yeah, thank you. Go ahead, Medu.
Yeah. Ms. Shaifa Palialil, next. Ms. Prajasha P, thank you. Congratulations. Dr. Nambuvartini M, congratulations for successfully completing the course. Next. Mr. Vinay Kumar Singh, congratulations. Mr. Musuman Sri Ramaswamy. Dr. Nisha Vasant. Congratulations to all the participants for successfully completing the course. Move ahead with the closing call. Next. Dr. Aditi Bansal. We can do quick initials. Miss Tiara, she was an international participant, so congratulations to her as well. She wanted to know the Indian standards as well, so quite enthusiastic. Congratulations, Iara. Next. Dr. Nadia, again an international participant. She was from Malaysia, and congratulations. Dr. Parvati Unni Krishnan, congratulations to you, ma'am. Miss Ashwini KM, congratulations. Dr. Devanshi B. Patel, congratulations for successfully completing the online course. Sylvester Vipin Kumar, congratulations. Dr. Reena Prajapati. Dr. Sri Devi V. Dr. Nidivanta Subramaniam. Anil Rao. Ms. Arugya Mari R. Congratulations. Ms. Sridevi Randasamy, congratulations. Ms. Vansali Roy. Ms. Ramya JL. Nami Dawn. Vikas Gavde. Ms. Tanuja Ashok Vihulekar. So congratulations to all the participants. This course wouldn't have been successful without your interactive participation. We have our faculties also with us, and they all truly appreciated your enthusiasm throughout the course. So a very warm congratulations to all of you. Wish you all the best. And you are now our alumni, and we're going to have a physical graduation ceremony at our upcoming CAHO next year. So we would like to see you there as well. So congratulations to everyone. And now, because we are about to end the valedictory ceremony, and I would like to propose a formal vote of thanks for first and foremostly to CAHO, especially to Dr. Lalu Joseph for being so supportive and for giving us this opportunity to collaborate with CAHO. This is the first time IIPHG has endeavored into the field of hospital administration as well. And we hope that we have been able to keep up to our quality standards as well. So I would like to thank Dr. Lalu and the entire CAHO team for the support. Dr. Anuradha, who was the co-project director with me, her support right from the beginning of the course, the planning of the course curriculum and how the sessions would be, everything, we were there together. So I would like to express my thanks to her, to all the faculties who were associated with us, CAHO, outside CAHO, IIPHG, outside IIPHG, to all of you, I would like to express my thanks to all of you. And would like to express my thanks to all of you and to the IIPHG, my director, my registrar, my entire team, Dr. Apurv, Dr. Kruti, who were there till the end. They were there to support for all the delivery of the sessions and every administration. Thank you to everyone. And Nisha and Meenakshi being the coordinating for all this course thing. So thank you, Nisha and Meenakshi as well. Congratulations to participants. This wouldn't have been successful without your participation. So that's it from my side. Thank you.
Congratulations, participants, and indeed pleasure having all of you. Looking forward to meeting you all at the formal, the ceremony where you'll all be wearing your gowns and will be presented with your certificates. Please block the date and time. It's going to be on the 11th of April at Chennai, 2026, 10, 11, and 12, CAHOCon. You will all get complimentary registrations to join us. Meenakshi will be in touch with you to share the registration. So please block the dates, 10th, 11th, and 12th of April 2026 at Chennai. Thank you. Wonderful. And thank you, Medha. Thank you, Dr. Apur. Thanks, Dr. Deepak, and my own team, Dr. Anu, and the group of faculty. And thanks to Dr. Jayan Srivastava for taking the time and for giving such a wonderful keynote address.
Yeah.
Thanks, Meenakshi.
Yeah. Thanks and congratulations to all participants. And thanks to everyone, and Lalu ma'am and Srivastava sir and all team members. Thank you.
Thank you.